Today's podcast is going to be looking at the temporomandibular joint, otherwise referred to as the TMJ. We have a few objectives that we're going to be walking through and looking to answer over the course of this presentation, specifically describing some of the bony structures, some of the major muscles and ligaments of the TMJ, as well as looking at some of the overall movements, physiologic, accessory, even at the discal level, and then finally defining some of the terms that are commonly used for the temporomandibular joint as well as the surrounding teeth. For those that are looking for some additional resources, some optional reading includes Mike Reiman's text, chapter 16, as well as Carol Oatis' text of the third edition, chapters 23 through 25. There's a few additional resources that I've used as well to kind of compile this overview and introduction to the TMJ. So first and foremost, recognize that the TMJ is the most used joint in the body during daily function, right? My ability to speak right now is using the TMJ. Your ability to drink, to eat. It is arguably one of the most important joints, not only in the fact that it enables us to communicate and interact with our surroundings, to enjoy food and drink and keep ourselves nourished and healthy, but it is also something that allows us just to interact with our environment. And it's made up of the joint between the temporal region and the mandibular bone, and it's entirely covered then by capsular tissue. It's a synovial condylar modified ovid and hinge type joint, and that'll be more apparent as we go. But there is a fibrocartilaginous surface. There's a disc versus hyaline cartilage, and that's really important because of the high amount of use that this joint sees. It exists between the upper and lower cavities in terms of where that disc is actually located. Now, when we look at the temporal bone of the skull, a couple prominent areas should emerge. First, we see the mandibular fossa. This is similar to the glenoid fossa that we see at the shoulder, and the fact that it's a concave surface, and that allows for the articulation then with the mandibular condyle. We have what's called the articular eminence, which has our articular tubercle, and then there's a convex portion to that. And then we also see the mastoid process in the zygomatic arch kind of connecting around into the orbit. On the lower portion of the TMJ, here we see the mandible, and this is the largest and strongest bone of the face. There consists of a body and angle, the TMJ angle or the mandibular angle that then leads into the rami and the condyle itself. The condyle then is going to articulate with the mandibular fossa of the temporal bone, and it's convex in shape. And so here we see kind of that illustrated. Again, you can see the mandible, you can see the temporal bone, recognizing then some of those various components that we were just talking about, things like the body, the rami, the angle of the mandible, and then extending upward into what we might refer to as the cornoid process of the mandible. That's the more anterior portion, versus the more posterior portion, the condylar process of the mandible, and then the mandibular notch that kind of is a saddle region in between the two, and then that's going to articulate with the more concave temporal fossa. The mandible is a pretty interesting structure. Again, it is the strongest bone of the face, but it also serves as the jaw, where we find the teeth, and then the portion that articulates with that mandibular fossa is kind of interesting in the fact that the condylar process here, we have a rather large head associated with that, and that really helps to distribute force, but also helps then with the mechanisms of chewing and phonation and being able to talk and articulate and move the jaw. And again, this is where we see then this disc, which we'll talk about momentarily, also articulating between these two structures. Here we can visualize a little bit closer the zygomatic arch that comes around into the articular eminence. We also can see posteriorly the mastoid process, which lies just posterior then to the TMJ. Now, the mandible itself has, again, the coronoid process that is anterior to the condyle, right? It's similar to what we see at the elbow, that being the coronoid process, the more anterior portion of the elbow lying anterior to the olecranon. So very, very similar in terms of kind of how it's structured here, right? Then we also have what's called the mental protuberance, which is more what we would consider the chin. That's more external, okay? And then if we go more proximal, we find the actual TMJ, the temporomandibular joint. And this is the articulation then between the mandibular fossa and, again, the mandibular condyle, right? And now you can begin to appreciate this articular disc. Now, this articular disc is kind of interesting. Again, we're going to talk about this in just a second, but it's what we call a biconcave disc, meaning there is a portion that is articulating with the more convex and portion of the mandible, and then the concave portion of the mandibular fossa. But then as we open, there is an anterior gliding that occurs there, and this is where that biconcave structure really is beneficial. And again, we'll talk about that momentarily. The maxilla is the upper jaw, so if as we're looking here at portions of the lower jaw, the mandible, the maxilla would be the upper portion. This is the attachment for the upper teeth, also forming the cheeks and the walls of the nasal cavity. This is also where the zygomatic arch is going to come around and attach. And then more proximal and superior, we find some of the muscles that are utilized with muscles of mastication. And so first we see the temporalis. This is a broad fan-shaped muscle that is located on either side, above the jaw, above our ear, and this is going to run both inferior as well as anterior. There are three parts. We have an anterior portion, we have a middle portion, and then we have a posterior portion. And you'll notice the angulation of the fibers changes for each one of those. From there, we see the masseter. Now, the masseter and the temporalis work together, but the masseter is one of the really strong chewing muscles, and it is both thick and really strong. So whereas the temporalis is more this broad fan-shaped structure, the masseter is more compact and very, very strong. It has both superior and middle portions that run inferior and posterior, but then there's also a deeper portion that's going to help again with the ability to chew and masticate. Next, we see the pterygoids. Now, the pterygoids are pretty important in terms of the TMJ. We'll see that momentarily a little bit more, but as a general overview, with our lateral pterygoid, this is the external pterygoid, right? It runs horizontally back, and it is the most frequently involved muscle when we see TMD. Now, TMD is temporomandibular dysfunction. Now, this is an important point. Many individuals will say, I have TMJ. This is a little bit perhaps semantics, but we all have TMJ, right? We all have that joint on both sides. When the TMJ begins to be symptomatic, when we begin to see dysfunction, then we say we have TMD, which is temporomandibular dysfunction. TMJ is not really a dysfunctional state, rather it is a joint. Okay. Now, the reason why this muscle is most commonly or most frequently involved is because of the attachment of the disc and the capsule in proximity to the pterygoid. Now, the pterygoid here, specifically the lateral pterygoid, stabilizes the joint during almost all the movements, and so commonly it's used and overused because of this role. It's also paired with a medial pterygoid, so we have a lateral and a medial pterygoid on both sides. The medial pterygoid, however, is an internal pterygoid, and it's going to run lateral, posterior, and inferior, and you'll see that here momentarily. So on this image, a couple things that we can see. First, we can see the temporalis and the masseter, both the deep and the superficial part that we've been talking about. A couple other things that we can begin to appreciate, specifically on the lower image, is the lateral pterygoid. So the lateral pterygoid is really found or seen kind of back behind, if you will, where that deep part of the masseter would be found. And again, this is the external portion when we're looking at the lateral pterygoid. If we want to look at the internal portion, well, here's the medial pterygoid. So you can see these a little bit better, right? So lateral pterygoid, right? We have two portions there, and here you can appreciate kind of the origin is really on the disc and the capsule itself, right in front of the mandibular condyle. Right? From there, we then drop inferior and we can see the medial pterygoid. Now, the medial pterygoid is the more internal pterygoid. And then if you look from kind of underneath what we call the posterior view, you can visualize that medial pterygoid a little bit better. It's actually coming in and inserting really on the roof of our mouth and then coming down and attaching, really originating, if you will, right off of the angle of the mandible. A couple other muscles that we want to be aware of. First is the digastric. There's two kind of muscle bellies to the digastric. There's an anterior and a posterior muscle belly, as well as kind of this intermediate tendon, and this will loop through the hyoid bone. So this is a fairly important grouping. We also have what are known as the suprahyoids, and then also the infrahyoids. And these all attach in and around to stabilize the hyoid, both above and below, during normal movement of the jaw. Here we can visualize those infra and suprahyoids a little bit better on both this lateral and anterior inferior view. We can also see their orientation of the digastric muscle as well, specifically the posterior belly. Now this image comes from Dutton's 4th edition, and you can begin to appreciate how all of these muscles begin to interact, right? So we have the infrahyoids and the suprahyoids that are helping with opening the jaw. With opening the jaw, we see the lateral pterygoid, specifically the inferior head, helping to draw the mandibular condyle into an anterior-inferior direction. And then with closing, we see that the medial pterygoid comes in along with the masseter and helps to close the jaw. And because the jaw is working, the mandible is working both left and right, when we have contralateral jaw excursion, which is shown in this image here, we have lateral and medial pterygoid helping with that. Right? When we have ipsilateral jaw excursion, then it's the temporalis and the masseter. Right? So you can appreciate here, if this individual is going to deviate their jaw to the left, right? It's your right as you're looking at the screen, but it's this individual's left. The ipsilateral temporalis and masseter are going to function, and the lateral and medial pterygoid on the contralateral side are going to function and fire. And so we can see this even a little bit better on the following image that actually comes from Carol Oatis's text, and this is the 3rd edition. So here we see lateral deviation now to the opposite side, right? And so here we can see the masseter as well as the temporalis, right? So that's going to be ipsilateral, right? And then very similar to what we just saw, we can see the medial and lateral pterygoid functioning now on the contralateral side, but resulting then in contralateral excursion or deviation. And it's primarily because of the origin and the insertion of these muscles. Okay, so to kind of bring all this together, to clarify, if you will, depression, when we open our mandible, this is the digastric and the hyoids, suprahyoids specifically. Elevation, meaning bringing the jaw back up, this is going to be temporalis and masseter, as well as the medial pterygoid, really acting bilateral. When we laterally excurge the mandible, right, we have the temporalis and the masseter functioning together, but then we also have the contralateral, medial, and lateral pterygoid that are going to pull that condyle into kind of a forward and down position. If we were to protrude, meaning kind of stick our jaw or our mandible out, okay, this is both medial and lateral pterygoids functioning bilaterally, and then to retrude, to kind of pull back in, this would be our temporalis, our middle and deep masseter, as well as some of the digastrics. So we've looked at kind of the general overview of the anatomy. We've also looked at some of the muscles of mastication. The next part then is we need to look at the joint capsule and some of the surrounding ligaments. The joint capsule is an articular capsule. It's surrounded and stabilizing the TMJ. And it also then is reinforced by the lateral temporomandibular ligament. And this extends from the zygomatic arch to the lateral joint capsule. Found inside that capsule is our disc. Now, we mentioned earlier it's a biconcave surface. It is fibrocartilaginous, and so it functions very similar to the meniscus, and it enables the condyle to slide over the articular eminence or the articular tubercle without becoming impinged, if you will. The condyle and the mandibular fossa are then kind of maintained in terms of their joint space, the upper joint space and the lower joint space, by this disc, with the outer edges of the disc attaching then to the capsule that we just saw. And so it divides really the compartment or the joint into these two quadrants, upper and lower quadrants or compartments. Probably compartments would be better. Their quadrants would be four. There aren't four. So we'll stick with compartments here. The movement then occurs in the upper joint space. Okay, lower joint space, not a whole lot. Okay, but the disc is going to follow the condyle. So as you open your mouth, okay, the condyle is going to slide forward and rotate. And the lateral pterygoid, remember the lateral pterygoid, you can see that in this image, it attaches to the capsule and the disc. So the lateral pterygoid is going to pull the disc right along with it. And what that allows then is it allows, that being the disc, is allowing the condyle to slide then over the articular tubercle or eminence in a very nice smooth pattern. So then you can see that with the jaw closed, the condyle is a little bit more posterior. As the jaw opens, lateral pterygoid pulls on that disc, also pulls on the mandible itself, and now it's going to glide forward and over the articular eminence. Now, there's a few other things we want to be aware of, specifically around the jaw. This is a common area for referral. We have some nerves and arteries in and around the area, like, for example, the ophthalmic, the maxillary and mandibular nerve, as well as the lingual nerve, the nerve to the mylohyoid, the buccal nerve, right? And so it's important to just appreciate some of these kind of neurovascular structures. Referred pain we'll talk about towards the end, but it's a common issue in and around the temporomandibular joint, and you want to ensure that you are approaching a differential diagnosis through a comprehensive fashion. Lots of movement associated here. We said that early on. The function of the TMJ is fairly wide. It's arguably the most used joint of the body. Motions that are possible would be depression, which normal opening for depression is somewhere between 35 and 50 millimeters. Most individuals can fit approximately 2.5 to 3 knuckles in their mouth. Specifically, it would be digits 2, 3, and 4, and you'd be able to fit those between the teeth of the upper and lower jaw. That can also be measured with what's known as a Bowley gauge to get more of an actual measurement, or you can just simply use a tape measure as well. Elevation would then be considered closing. And then the other three that we see would be lateral excursion, which is lateral deviation, protrusion, and retrusion. Now, lateral excursion, that's kind of the side-to-side motion. It's typically a 1-to-4 ratio as it relates to depression. So if depression is close to maybe 40 millimeters, lateral excursion might be 10. If it's closer to 50, it might be as much as 15. If excursion is considered normal, then when we say deviation, that would be the term that we use when there's abnormal movement, meaning there is perhaps an asymmetry or there's pain that's provoked with the movement side to side. Protrusion is the protraction, or what we call the jaw jut. The jaw kind of juts forward or in a more anterior direction, whereas retrusion is retraction. It is kind of pulling the jaw back. Now, we've noted a couple different components with movement. It's important that we look at this just a little bit further. And so with opening and closing, that being the most normal movement of the jaw, there are some both physiologic as well as accessory or articular motions that we want to be aware of. Again, we have this interarticular biconcave disc, right? The upper joint is more plane and gliding, whereas the lower joint is more of a hinge joint as well as a degree of rotation. So as we open in the early phase, there is a roll in the posterior direction as well as rotation and slight translation anterior-inferior. There's then a slide or glide in the anterior direction as well that enables the portion of the mandible to glide over that articular eminence. So it kind of unseats from the mandibular fossa and will glide anterior-inferior. The inferior part is really important, otherwise it's not going to make it over that articular eminence, right? And so that's with the more late phase of opening. You've seen these images before, again, just illustrating the role that some of these various muscles play. Again, the lateral pterygoid, really important for pulling on not only that portion of the mandibular condyle, but also on the disc to bring it along, such that everything stays in unison. As I mentioned just a moment ago, we have kind of two basic accessory movements. We have rotation and translation. Okay, rotation of the mandible occurs within the fossa. It's a down and forward or an anterior-inferior portion. There's also translation. There's a glide of the condyle, right? And so the rotation is going to be, specifically with opening, more of a posterior-inferior rotation. Okay, as you close, it's going to be more anterior-superior. Right, and then this translation also occurs. We also then have a glide and a slide, right? The third component is really only associated with lateral excursion, and that's a degree of spin, and that's because we do not have a glide there, okay? So it's more spinning around a stationary axis, and that is of the condyle that remains within the mandibular fossa, but then more on this vertical axis. With depression, it has to rotate, right? And then it translates, it slides forward over that articular eminence. The disc follows the condyle, really because of that lateral pterygoid function or action, okay? When you elevate, the translation has to occur first. The condyle has to slide back into that mandibular fossa, and then it's going to rotate back into the resting position. So if we see kind of all these phases together, here in image 1, we have the condyle really sitting within the fossa. The disc is in its place. This is normal depression and elevation. We move kind of clockwise all the way around. You can see the disc adopt more of that anterior position, and then it goes right back to where it was. So here's this idea of spinning, right? Ipsilateral spin, whereas we have a degree of contralateral translation. So if we are deviating to the left, right, the left mandible is going to spin, whereas the right, that being the contralateral side, is going to glide forward and downwards. That's that anterior-inferior portion, okay? Again, with protrusion, they should translate symmetrically. This is not ipsilateral versus contralateral. They work together. Okay, and then with retrusion, it's just the opposite. We've talked about that. And then really the last position here is the resting position. What's the resting position of the TMJ? It's with the teeth slightly apart, and that's really maintained then by the temporalis muscle. A little bit of terminology to be aware of. This is regarding then the teeth. We don't normally think of the teeth as being something that physical therapists are working with, but because we're working with the TMJ, it's important that we recognize some of these different terms. The incisors, those are the 4 front teeth on both the top and the bottom. Next to that, you have the canines. Those are the longest teeth. They kind of stick down a little bit. Then you have premolars and molars on either side. Typically in most adults, the third molar is the wisdom tooth, though that can sometimes be removed, or the 12-year molar can be removed and the wisdom tooth will kind of come in and take that place. And as a whole, there are approximately 32 teeth in adults. The ADA, American Dental Association, takes care of the numbering. The numbering looks something like this, right? So on top, there are typically 16. On the bottom, another 16, giving us a total of 32 teeth. Now, some different positions of the teeth and the jaw can affect the TMJ, so a couple more terms to be aware of. Bruxism is called grinding, and oftentimes a dental orthotic or device may be worn to prevent that. Trismus is the inability to fully open, and oftentimes that is because of hypertonicity in the muscles of mastication. It also can be from a TMD, temporomandibular dysfunction, and we'll discuss that as we get into lecture. Overbite is a vertical overlap, and that's what you see illustrated here. The distance between the top incisors and the lower or bottom incisors is typically 3 to 5 millimeters. When it's in excess of that, it's considered an overbite. And then there's what's called overjet. And overjet is where there's a horizontal overlap, meaning the distance between the top and the bottom central incisors is illustrated by B in this image. And so normal here would be 2 to 3 millimeters. In excess of that, for both overbite and overjet, would be considered pathologic or abnormal. An underbite would be just the exact opposite. The bottom incisors are going to overlap the top teeth. And then finally, we have what's known as an anterior open bite. And this is where the molars meet, but the incisors do not. And so they're unable to touch really that front row of incisors and even canines with the bottom. And this is just because of a morphologic change within the maxilla and the mandible. Finally, if you remember all of those neurologic structures that we saw earlier, right? The TMJ is an area of significant referred pain, not only from those structures, but from others, areas that refer to the TMJ. Certainly the cervical spine has a role here, the teeth, which we just looked at, the head, and finally the heart. You will remember when discussing signs of cardiac distress, jaw pain is commonly included within that. And then the TMJ can refer to other areas as well. It can refer to the ear as well as all of the above, the cervical, the teeth, and the head. The only exception there would be the heart. And so what's the takeaway from this? Well, when you are working with someone who is complaining of dysfunction of the temporomandibular joint, it's important that a comprehensive examination is performed to ensure that there are not surrounding complications related to the cervical spine, related to the teeth, related to even cardiovascular function. And so if you're working with someone who is complaining of TMD, ensure they are being seen and followed by a qualified dentist, and then also ensure that you are performing a comprehensive examination and evaluation to take into account all the different components that could be contributing to their signs and symptoms. And so with that, we're going to wrap up this overview of the TMJ. Things to really be looking at would be to understand the accessory motion, what occurs with opening and closing, as well as the lateral excursion, ipsilaterally and contralaterally, both at the level of the joint, so that more accessory level, but also then with the muscles of mastication. Remember, the lateral pterygoid is the big kind of mover and shaker because of its direct attachment to the capsule and the disc itself, followed by the medial pterygoid. And then other big muscles of mastication include the temporalis and masseter. So certainly reach out if there are any questions. Hopefully this review has been helpful as you refresh your understanding of the temporomandibular joint. Thank you.